So here we go. We have 1:30. We're going to get started. Welcome to Webinar Wednesday, everybody. Thank you so much for coming. I just wanted to mention your CEU request, and the recording of this will be up on our website probably by tomorrow afternoon. And so if you want to request CEUs, you can do so that way. We do have these scheduled through April now. So keep coming back. Not next week, but the week after is Nikki and I are going to do caregiver support. So very important topic. So talking about supporting those that support us. But yeah, I think that's about it for today. I don't have a lot. We are doing virtual office hours too, every other Wednesday, opposite of this. So if you ever need anything and just want more of that one-on-one conversation with us, you can pop into that and join us for that. So otherwise, you know how to find us. So I'm going to let Dr. Alla take it over.
Fantastic. Hey, nice to meet all of you. I'm just going to give you like a quick heads up of who I am. I have been in practice in Fergus Falls with my husband for 25 years. I'm a chiropractor by training. My time has been spent in brain. I've been trained by the world's best. In fact, I am in awe of knowing some of the biggest, best researchers in the world, in the universe of our world, that are looking at brain differently, looking at function, looking at structure, and looking at what normal is and what it looks like when there's a mild traumatic brain injury to obviously a more complex brain injury, and being able to understand that the observation of that client, if they are still ambulatory, their gait, looking at their facial expressions, looking at their breathing patterns, looking at their postural reflexes, looking at their postural stability or instability, looking at all of the typical bedside neurologic markers to really hone in and pinpoint or differentially diagnose the exact level of the lesion. And so when I say level of the lesion, there's a lot of misconception in the world of brain that everything is in the cortical area, where the majority of it is subcortical. We are cortical structure, we are cortical beings, but we also mostly are not in a conscious state at all times. We're mostly living through reflexive actions and movements. And so when the brain is injured, it is those reflexes that really show their face to us and allow us to understand more about brain. Because as you know, if you've worked with people or one of you are a sufferer of brain injury, you can't always just test the cognitive parts, because the brain will not allow cognition to be the primary thing if the heart rate's out of control, or the blood pressure is not controlled, or the actual respiratory rhythms are out of sync, or that the body and the gut can absorb and grow and have girth and have nutrition. So really the human is so much more reflexive than it is in a state of cognition. I mean, you can simply lose attention just like that, and it's all the reflexes that maintain your upright posture. And you can be in a place or a space, you can hear something, you can see things, but you're not necessarily present to those things. So when we see and assess people that have had mild traumatic brain injury, that being, I don't know how to turn off the phone, so forgive me. Because I'm in someone else's office this afternoon. Sorry about that. Hopefully it doesn't make too much noise for you, but when we're able to be in front of a client and look at the majesty of what function is there, instead of focusing on what lack or decreased function there is, it's pretty amazing when you go through just the algorithms that you're taught in school of how to assess. So simply tapping the thumb to see if there's contraction, looking at the visual system, just actually looking at posture, looking at how they get in and out of a chair, and not going into the assumption it's because their leg is paralyzed or they have lost sensation in that leg, but truly looking at the strategies that they use to understand the level of where that true problem lies. And unfortunately, as many of you know, and I don't know where you are in your part of your client care or client support, but we'll go through that in just a minute. Depending on where you are in that journey of that client's recovery, you may unfortunately pass the buck of this is what they have and this is what I want you to do, where we don't always know if that was really what it is and if that's the primary course to take. So being trained by some of the world's masters that don't use drugs or surgery in their approach, rather using observation, looking at the depth of a neurologic assessment, looking at the psychiatric assessment, looking at other historical factors, looking at, just general physical health or wellness, looking at blood markers, looking at everything to truly come to what the level of the lesion is, and looking at the 5 main things that they suffer in light of an injury. And the 5 main things being, number one, their sleep dysregulated. They can't sleep. And so right away, you know that their energy is going to be compromised. Certainly thereafter, you know that their mood's going to be dysregulated. There's going to be all over the place types of moods. Certainly when there is stress in their life, their coping mechanisms are broken. But it's not necessarily that there's stress in their world, because stress is never ending. It's always there. It's not going anywhere. It was there before their injury. It was after the injury. But it's the coping mechanisms, and not necessarily at a cognitive level, but more so at a visceral level, at an autonomic nervous system level, at a level where it's measurable through whether it's a blood pressure, a heart rate, a respiratory rate, a heart rate variability, looking at pupillary sizes, looking at whether the eyes have the ability to make tears, looking at dry mouth, looking at swallowing reflexes, looking at sensory systems, looking at it in such a different lens, if you will, really gives us an opportunity to get closer to the level of the lesion. And so I think in the future of neurology, in the future of brain, in the future of counseling, psychiatry, psychology, pharmaceutical use, non-pharmaceutical use, maybe using other modalities, whether it may be chiropractic or physical therapy or OT, speech therapy, all of it is going to have a very, very big paradigm shift, because if we don't pay attention to the sleep and we think we can use a chemical agent to allow the brain to go into a restful state, we're wrong. So I'm going to bring you some content that maybe you know, that maybe you've never heard, that maybe you've heard something on. And I would really love if you could turn on your videos so I can see your beautiful faces. I sort of am kind of a hard one on that, because I would like to have a conversation. Thank you so much, so that we can really help other people. Or if you're a person who has suffered as a result of some sort of trauma, then, let's have a conversation. Let's give it an open floor to ask questions, have a conversation about what works, what maybe trumps you up a little bit, or maybe how to approach it next time. So I would love, Carly, if you could facilitate giving everybody a shout out and asking them to give me some feedback on what their superpowers are, your magic skills, who you are, what you do, what lights you up. I want to know what lights you up. That's like the most important part of this conversation. What lights you up? What lights you up?
All right.
Why do you show up, right?
Yes. Okay, I can start and then I'll just kind of call on people. We'll go around. So I'm Carly Andrews. I'm the outreach coordinator for the North Dakota Brain Injury Network. I would say what lights me up in relation to brain injury is our just the inspiring stories that we get to hear all the time. I really like when we do our unmasking events. It's kind of an art therapy, and getting to see the masks people create to tell their story of their injury is very, very inspiring. So
love that.
Gonna go in order. Kyla, do you want to share? You're next on my screen. I don't think I've met you yet.
I'm Kyla Loud. I work for Generations Home Care in Chandler, Arizona, but
Ooh.
I grew up in Aberdeen, South Dakota, so okay. Don't miss the weather. But I actually work pretty much strictly with veterans, and so I work with a lot of TBI All my warriors have severe TBIs. So I'm just looking and trying to learn ways to help them, because, you know, a lot of it, I mean, is, you know, just the different traumas that they've been through, and trying to break through those barriers and figure out what will work for them to get them to do the things that we need them to do in our program. Not just for our program, but for them personally. So yeah, just working with veterans and trying to figure out how to navigate, you know, their injuries and different things. So
Kyla, can you give us an example of a client of one of our vets and just run us through from the point of time that you interact with them and what it is that your program looks like, so we can get a better understanding, because we need to speak. I have a lot of things that are available to veterans.
sure. So we are part of the independence program for wounded warriors. And so I actually have 3 warriors that I work with. We're contracted with Neuro Community Care. So we're not directly contracted with wounded warriors. And I have one that was severely injured in an IED explosion. He lost like a good chunk of his skull, and then they had to take out part of the frontal lobe because of the brain swelling. My other one is he got blown up a little bit, like there was an IED next to him. So his is more like survivor's guilt. And then my other one is just, he got blown up too. So I have a lot of TBI.
So what types of things do you do in your program? For example, the first gentleman that you spoke of that lost a chunk of his skull and his frontal lobe. What are his current main residuals that you are trying to help him through?
Well, because of the injury, he has his speech is, you know, not where it was. He was a very highly decorated ranger, and so getting through that part of him to realize that, you know, he's not ever going to be the way he was, and to get him to try and focus on what he can do. We do a lot of, his whole thing is about working out. So we do a lot of that. So really a lot of it is to get him to interact more verbally, because when he first came out of the coma, he couldn't speak. So he does a lot of sign language. But since I've been working with him just for like 2-3 months, he actually has conversations with me now. And it is amazing. You know, you have to really listen close to him, but the more I'm around him, the more I understand it. And he's just, you know, that's the thing, is to get him to communicate more. That's one of our goals, is for him to reach out to his, you know, people that he served with or whoever his friends are, video or phone versus just texting, because he's really big on texting.
That's fantastic. What lights you up, Kyla?
Man, just working with those guys, because when I was in the Marine Corps, I was in from 91 to 95. There was nothing going on. I didn't do war. I served in Barstow, California, and Camp Pendleton. You know, I didn't do anything like that. And just seeing their, you know, their journey and what they've gone through and where they're at in their life, they're my heroes, and I'm just honored to work with them. So they're
my heroes too, and I'd be a Marine if I was born in this country too. So thank you for your service. That's fantastic. I love it. Let's keep connected and have some conversations off of this call, so we can keep this one going. Thank you so much. Great share.
Nikki, you want to go next?
Nikki, what lights you up, Nikki?
You know, I just like being able to learn more about what resources are out there for our individuals, so that when they contact me, have a great place to say, hey, did you reach out to maybe Ala? No,
what is your company or industry that you're currently serving?
I'm with the North Dakota Brain Injury Network.
You help the injury. That's why the backdrop is the same. Okay. I didn't know what role you had. That's awesome.
The resource facilitator for the.
Okay. Thank you.
Yep.
Nora, do you want to go next? You're on my screen next.
That might help. I don't know if I'm out of place here. I'm
No,
a
you're not.
patient in cognitive therapy. And this just sounded really interesting to me, so I wanted to.
And we'll make it interesting. What lights you up, Nora? What makes you want to keep doing everything you can do?
I was in such a horrible place. I couldn't keep living that way. And there's been a lot of progress. I have a long way to go, I think, but I've come a long way too.
Awesome. You're in the right space. You're going to learn a lot of information today, and that's great. And if it seems like it goes too fast because I talk too fast, don't worry, I repeat myself.
And
Okay,
we're,
if
that-
you have-
we're
that
recording this
helps.
too, so.
And she's recording it, so I'll try and speak a little bit less Canadian-like, but I can't promise it. Thanks for being here, Nora.
Sarah Masters, you want to tell us about yourself?
Okay, there we go. Okay, I'm from southwestern Pennsylvania, and I'm a music therapist, and I work with Wounded Warrior. I have, let's see, I don't know if I can show you the picture. There he is.
Oh, I love it.
Nice.
So he also got hit by an IED. He's nonverbal, but he can understand language. So a lot what concerns me is how to use. He can make sounds and how to use his sounds more towards communication. They did try that where they said 10 years ago when he first had the brain the injury. But I know myself, I had a concussion, and it took 9 years for a lot of it to come back. And for me, it's like, why not try again to get him more communication? He definitely understands. Like they say, do you want to listen to Carrie Underwood, or you want to listen to reggae? And he'll like smile for one and not for the other. He understands quite well, and he has a baby, so he can't sign language because he only has one hand. What I do with him, he'll play on this keyboard one note, and it'll play a whole chord and percussion, and then so we have like nonverbal communication. So I guess that's all. Yeah.
That's awesome. Being that you are, tell me your specialty so I don't say it wrong. A music
Therapist.
Okay. I thought that's what you said. Then I thought, well, maybe she didn't say that. What kind of things do you do with music other than him giving you feedback on keyboard, or just like listening to music? Are you interacting one-on-one with him or through Zoom?
One-on-one.
Okay.
Because of COVID, he's the only one I'm working with because of COVID. All the institutions were shut down in Pennsylvania. So another thing, he was on his own starting to hum to match the pitch that he would play on the keyboard, which is pretty amazing. But because he hadn't been vocal before for years, I guess he was years ago. Let's see. So sometimes I try to use art, like crafts or something, and I draw stuff and communicate with him that way. And then he uses rhythm instruments to, there's a nurse that it's hand over hand he has to do, but he definitely directs it. So I got him a tambourine and different rhythm instruments. And someone before me worked with a guitar that they would have, one person would hold it, and then he was able to, with help, strum it. He used to be a good guitarist, and I'm not a guitarist, but he used to be. He loves that.
Can he whistle?
No, I don't think so. It's hard to get him even to make a sound. But some of it is he has congestion, and he'll start to cough and stuff when he goes to make a sound.
Okay. The one thing that you want to
Nora's been
consider.
raising your hand. Nora, you go ahead. Do you have something to add or?
Yeah.
Question? Nora?
He has one hand.
Oh. You
No,
wanna-
he has two hands, but he's paralyzed, half paralyzed.
Got it. He's paralyzed.
Oh.
Right, but I took a sign language class with one hand,
Oh,
and they could understand a whole lot of what I said. And I, of course, could understand them as I learned more and more.
sure.
A lot of it, I mean, some of it I couldn't do, but a lot of them, it was like you do the same sign but just use both hands. And so I would just do half of it, but they'd know what I meant. I just thought I'd let you know that maybe it's something to look into at least.
I didn't know how he can't really move his hand. Someone has to, help him move his hand, and then he leans into it.
Oh,
So
I thought it was just one arm that was paralyzed. I'm sorry.
no, that's all that's left is one hand that he can use with help. And-
Okay,
But
I'm
but
sorry.
maybe there
Yeah.
is a way though, because he definitely with smiles and like he have a broad smile if he likes something, and his head will go down if he doesn't. So maybe there's a way to work it. I don't know. That's one thing that I'd ask anybody here if they have ideas.
Kyla, go for it.
So he has limited use of his one hand.
Yeah.
My partner used to work for the state of South Dakota, and she worked with a lot of, the state aides. And we had a guy that had absolutely no communication, and he had a board that he was able to
Yeah.
punch in, and then it would speak back to you. And then they had some stuff that was already programmed in. That board was amazing.
Yeah, they have he does have a Toby board, and I've asked about it because I like those. But he gets all worn out, so he's only able. So I ask, and they say he just used it for half an hour, and he can't. He's too tired. But he is able to use like an iPad to play tambourine or something now on it, which is sort of similar. Yeah, I should.
Yeah, it's that energy level that is the problem. That's so much tasking trials that creates so much running into the wall. So you might want to consider with him just doing some manipulation of his tongue, like getting a toothbrush and start pressing down on it so it starts to understand weight. And then when you have
No
that
COVID,
stimulation
no,
on the tongue,
No, I would not, I know you don't want to go to COVID. No,
who's
this,
got there you go.
I muted. I think it's from Kyla's end. I don't think it's her, but it's okay. It's okay.
Oh, no worries.
Yeah,
You may want to, for any of you who have clients that are having difficulty speaking or enunciating, a lot of times it's not the inability to speak that they have, it's the inability to control the jaw and then control the actual protrusion of the tongue. So when you put some weight on the front of the tongue, the back of the tongue starts to have a swallowing reflex, and that swallowing reflex can clear the back of the throat. And then with that stimulation and that weighted response, then you want to start doing ahs. And don't have him hum. That's too much work because he can't breathe efficiently. So if you cut it into segments of just staccato, which
Yeah.
just the
Uh-huh.
and you start to get air exchange going out instead of always swallowing air, you're going to see his belly distend less. He will be able to breathe better, and he will be able to start to create a better swallow response and have less of that congestion in the back of the throat, allowing him to have more energy, which is what you're looking to kind of capture, so that when you're working with him, you can train him. And it's a really helpful technique and literally just use a brand new toothbrush, or if you have tongue depressor or something that can be thrown away. And you don't want to probably create a gag response if you're not trained and being careful on causing choking. So if you stay at the front part of the tongue, it's a great way to create stimulation. Of course, inform the client what you're going to be doing. And that's a super one. Can he chew his own food?
No, he has a colostomy.
Yeah.
Bag.
And that's fine. But when you get into that tongue and you start to create that reflex of just swallowing your own spit. Like literally, I know it's terrible to
Right.
think that that's it, but another one that you could do, and you can get permission from his doctor, is use a sucker as your pressure and
Huh.
start working, because what that will do, obviously, will create more salivation.
Yeah.
And you want him to promote swallowing. First, start with a dry toothbrush, work and create some plasticity in his ability to tolerate and not be aversive to it, to be welcoming of it. And then you can progress to trying to do something that has a little bit of a stimulatory, gustatory effect, because he still has that reflex. And I tell you what, for him to taste something is euphoric.
Oh, yeah.
And that euphoria is what's going to drive the brain. It's going to drive blood to the brain, and you're going to build plasticity and help with him have a little bit more energy for the things that he would like to learn or do or be able to interact with.
Okay, so good ideas. Thank you.
You're welcome. Anytime. Glad to do it. Any other questions on that one while we're on just swallowing and energy and the fact that the airflow is the key ingredient to be able to manipulate the tongue. So you can also, as an aside, Sarah, have him try and touch the toothbrush as you progress, and that's going to change the jaw position. And when you change the jaw position, it's not going to be retracted, because he can't talk because you can't push it forward. So when he can protrude that jaw forward, that's going to be a game changer. So even just stimulating the jaw and giving him just some facial stimulation in the forward direction to prime that area will be a really helpful thing for him as well, or for anyone else who maybe can't swallow well or has sensitivities to different textures. There's no texture sensitivity. It's a proprioceptive problem in the tongue. They don't understand how to manipulate what that actual weight is from the object that they are currently trying to manipulate, resulting in an aversion. So neurology is changing. There's going to be a lot of different things available and a lot of different thought processes coming forward, because the airway is the most important way. And if the airway isn't good, you can't teach speech, you can't talk, you can't do anything. So that's the one thing as a musician and a music therapist, that respiration is the most important thing.
For,
Make sense?
for a
And
lot
keep
of
it
yeah.
keep it staccato. Keep
Yeah.
it not long, because you can't maintain the airway.
Mhm.
Cool. Thank you.
Okay.
Awesome.
Thank you.
Sandy, you're up next on my screen anyway.
Sandy, what lights you up?
So what lights me up is walking outside on sunny days.
Love it.
And my story is I'm a stroke survivor myself. And I do some work in the state of North Dakota with stroke support for survivors, and if caregivers want to join in.
Tell us your story.
I had a subarachnoid hemorrhage, so a spontaneous thing almost 7 years ago. And I was blessed with not many challenges, but I have enough that I'm not able to work. And so I just have tried to kind of embrace this new life.
Where was the hemorrhage? What part of the brain?
Very occipital, kind of
In the back, in the base?
where subarachnoids are.
Was there any change in your vision right now, or your depth perception?
No.
Nothing. What residuals do you have?
Well, it apparently, according to my doctor, woke up a migraine center in my brain, so I have headaches often. So I have difficulty concentrating for long periods of time. Get overstimulated with, if there's too much noise going on, I can't multitask very well. Math is terrible. Sometimes writing, I can't figure out what the next letter should be, or I know it's an L, but I don't remember how to make that letter. And a lot of that has improved greatly from the first year, but I still notice it at times. Those are kind of the biggest things.
Appreciate the share. Thank you so much. I'm glad to have you here. Awesome.
Lori, you want to go next?
Sure. Sure. I work at Vocational Training Center, work with individuals with intellectual disabilities, but I also support some individuals with TBI that they received very young age.
Okay.
Sure.
You know, and I guess what really lights me up is going to these webinars and finding out information, because I'm definitely finding out and working with individuals with TBI that a lot of teams have no idea how to support them. So to use the information I'm gaining to help the individuals have a more meaningful life.
Yes. So what are the things that you have noticed, Lori, with, let's keep on that topic of TBI, because that's what you just referenced. What are some of the consistencies that you see in your clients that it seems like everybody has that same problem?
I would say taking in information, you know, expressing, you know, when I first came on a person's team, they did not let me know that there was nothing in her file that she even had TBI, and they had her on a behavior program. They said, why are we not looking at where we need to start her support versus having a behavior program? You know, so I help rewrite that basically. And we're talking behavioral analyst, you know, again, just not looking at that as a place to start. And now, you know, one of my questions too, a lot of these three individuals I'm thinking of definitely are aging. And so I've seen where they are become more frustrated, their language skills. You know, you can talk to one of the gals and it's like you think she's understanding, and then she's asking the same question that you just talked about. You know, so to me, she didn't get it. Work with a gentleman. He has a hard time making choices, even though when you know what he really enjoys, if you give him two options, it's whatever you want. I mean, he has a hard time making those choices, but also
You always have to, Lori, you always have to give them 3 choices, not 2.
you know,
Can't give 2.
Even 3. I mean, even very minimal is a hard time, very hard time.
So give me an example of perhaps a scenario that you're having a discussion with him and giving him a choice, just so we understand a little more depth.
When there was a ground round here, we would go out, and because I would try to help make connections with friends, and I knew that was his favorite restaurant, and I asked him where he would want to go, where they serve good food, where the food comes from the earth, but it was hard to make a choice, a decision of any kind.
Got it.
Yeah.
And these folks that you are referencing were injured at a young age.
Yes.
And the type of injury was not a mild traumatic brain injury at that point. It was a major because of an accident, or what was?
Yeah, one was an accident. She fell off of her aunt's lap. I think she was a couple months old. Another one was shaken baby. Another one had encephalitis.
Okay. So functionally, are they pretty able yet, or are there other bodily disabilities, postural disabilities, gait disabilities?
No, they're pretty independent. With support,
What do they complain of with respect to sleep? Do they tend to have problems with sleep?
You know, not that they've ever expressed.
Okay. And those are going to be, you know, write down these 5 pillars for yourselves as brain experts and in the brain industry, or people suffering with something that has happened to your brain, whether it was, you know, encephalitis, or it was a subarachnoid hemorrhage. Perhaps it was PTSD from multiple abuse. Perhaps it was as a result of fear-stricken PTSD. Something happened. You may not even know what happened, but you feel blocked and stopped and stalled and stuck. The number one questions are to rate. Number one, how would you rate the quality of your sleep? You know, and rate it however you want to, 1 to 10, 1 to 5, whatever your rating scale is for yourself. Good, bad, indifferent, you know, whatever you want to use as a rating. So after sleep, you must ask the next question is, how would you rate your energy? Don't assume that they may have no energy if they don't sleep, because that's not true. Some people don't sleep and they have energy for whatever reason it is. Everybody's definitely wired differently. The third question that you're going to want to ask, so number one, the quality of your sleep. The number two question is, how much energy do you or don't you have? How would you rate your energy level? Number three is mood dysregulation. Do you have a lot of dysregulation in your mood over nothing? Can you wake up feeling just lousy about the world, very negative? And on the other hand, do you wake and say, I'm devastated, and that's the other extreme, I don't care anymore, I'm done? Where would you fall into that rating scale? And, you know, have that consistently as a question to these folks with anything related to brain. It doesn't matter what the brain injury is. It's always the 5 pillars of questions that should be asked. The next question, number 4, would be, how do you cope with stress? Don't give them your assessment, ask them. If they don't understand what you mean, you simply say, when you walk outside and it's super cold outside, how do you feel? Or for Kyla, when you walk outside and it's super hot outside, how do you feel? You can also ask them a simple question. What does it feel like when you walk into, you know, Hobby Lobby? Don't assume. Ask them how they feel. They're going to tell you, it pisses me off. I get stuck. I feel dizzy. I want to puke. I love it in there. I mean, I don't know what they're going to say. They're going to say whatever they say. And then the 5th question you always want to ask, how clear do you feel in your head? Do you feel clear, or do you feel like you're in a fog? And keep the questioning super ordinary. Just be an ordinary human being, not a clinician, not being someone who's trying to assess or evaluate. You're just wondering how they feel. Do you feel rested when you wake in the morning? I feel totally rested. Some people will say that because they are rested until they stand up. And when they stand up, what might change? Gravity. Gravity now became part of their problem because it's a constant. And their fatigue is not based upon the lack of sleep, because they may have slept long enough to get enough to feel like they have energy. But the problem is, as soon as they have to stand up and go from, you know, laying down or being in a non-gravitational surface to a standing biped 2 feet, now the world changed. It's a great question to ask them. How do you feel when you lay down as compared to when you get up? Do you find that when you lay down, everything just wants to actually feel better and go to settle without sleeping? Just lay down. If you're feeling dysregulated in how much energy you have, if you feel sleepy, if you feel like your emotions are all over the place, if you're feeling like you're not coping with stress and starting to feel the angst of anxiety, if you're having some fog in your head and you lay down, does it change? It changes every single time for every single brain injured person. Because when you take gravity out of it, they don't have to work so hard. So that's a huge component for when you're working with your clients. If they are trying to communicate with you, you're perhaps doing some vocalization. Lay them down, do the vocalization there. Get them out of gravity and work their way up as they build plasticity. Because otherwise, just being upright may already poop them out, and then they can't learn. So consider that. It's a huge element, because when someone's had anything to do with their brain, whether it was an infection, whether it was a PTSD, they will often say that there's a sense of motion. They may not use motion, but they'll say that things don't feel still. I feel shaky. I feel vibration. They feel some sort of motion when there's nobody moving. And so what that tells you is that gravity keeps pushing them down and they come up. And it pushes them down and they come up. And so they are bobbing. And that motion is very fatiguing. because typically they're not getting up and running a marathon. And so they already have some deconditioning. Typically they don't have great respiratory efforts. So they have to work to like get that breath of fresh air so hard. And then you ask them to do it again and they're like, oh my goodness, how many reps of this breathing stuff are we doing today? So consider when you're working with someone who may be fragile, and they may be going from fragile to more to complex, where they're no longer as fragile, when they're going from complex to becoming more robust. That's when you start to change how much you make them work. Reps and sets don't matter in brain. What matters is fatigue. And if you're training a client, or you are a person that's working with a trainer or a therapist or a doctor, and if you're trying to do the reps and sets and not paying attention to your level of fatigue, if you're the clinician, you're going to crash them. And if you're the client, you're going to get crashed. So it's a super important thing for you to give them more rest than more reps. But that doesn't mean they sleep all day. You give them a rep and then you say, go ahead and have a rest. And they're grateful for that rest. Sometimes it's just give them some water. Sometimes it's just have them close their eyes. For some people, they can continue sitting. And if they close their eyes, their brain can reset. It gets a chance. Excuse me, I talk too much if you haven't noticed. But hopefully that element is helpful for you to, number one, check the 5 pillars of brain. And then number 2, figure out how they're doing in their level of gravity, and whether when you're working with them, you take them out of gravity. Another thing is, if you want to really get out of gravity, go put them in a pool. If you're able to keep them buoyant, that is going to give you remarkable understanding of their progress. Because now they don't have the constant of the world pushing them around, and they can float and learn faster, and they don't get fatigued as fast. So that is something that you're going to certainly see in the world of brain, is just being able to be in a state where they're safe, they're preserver, they're okay, and that level of floating, fantastic. Even a hammock, that can be another way to do some rehab. Put them in something that they are literally almost in a state of buoyancy. It's a game changer, because what it does is it offloads all of the muscle spindles and all the Golgi tendon organs, which are sensors in your musculoskeletal system. So your musculoskeletal system takes a lot of energy, and it's always trying to right itself to gravity. So if you can take that load off and you want to do some cognitive training, some memorization, some recall this, recall that, remember where this location is, here's the restaurant, what's the name of it, show them the outside, don't show them the name, and say, tell me how to get there from here. Whatever it is that you're going to use. And rehabilitation, or whatever you want to call it, helping someone be the best version of themselves, is all about being creative, but with a specific map of creativity. You're like, how can I make this happen for them to make it, they want to have progress. If you keep making them do the same thing over and over and they see no progress, because they don't usually lose their cognition in a head injury. They're usually very cognitively sharp. They just can't get it to you. They have all their smarts. Their intelligence doesn't change after an injury. What changes their ability to be able to actually relate it to you in a way that you are understanding of it. But their intelligence isn't compromised. Rarely is it compromised. So when you're thinking about doing any type of observation, assessment, or at some point rehab or therapy, or whatever it is you're going to call it, you've got to realize that sometimes you got to use the simple stuff, which makes the most outcome. Simple stuff, simple stuff. So I was thinking with Sarah again about music. I wouldn't give them music. I would give them a tone, one tone, one tone. Identify this tone. Try and mimic it. Try and make that sound, just one sound, because 2 is too many. And if you have 3 or 4, they vibrate, And the way that the brain is oscillating at the time that it hears that signal can be complete chaos in their ears. And in yours, you call it music. And they're like, turn that noise off.
Yeah, I was letting him touch one key on the keyboard, so he was getting one tone when he chose to vocalize, but a lot of times he won't vocalize most of the time. For years, apparently, they say.
And again, you know, for him, there's so many factors. If he's not swallowing, he's got mucus. I mean, like,
yeah,
he's probably vocalizing. You just unfortunately can't retrieve it because he's trying to work through who knows how many barriers.
Yeah. I also wanted to mention, I had a tooth replaced, and in between while I was gone, I would talk to people on the phone and they couldn't hear what I was saying. I was still saying it the same way, but like the S's and T's were missing. And I thought that's sort of like with the brain, you know, you think you're saying it right, but then, I mean, even Siri couldn't understand me. And you say it right, but they don't hear it right, and it makes you feel like something's wrong with you, but it was just my tooth missing.
Yeah, exactly. And now your jaw is going to respond differently, and now your tongue is responding differently because it's always going to that area, because it's like, where did it go? Where did it go? Where did it go? And then you try to, you know, communicate a word, and you're like, superfragilistic. And your brain's like, I said supercalifragilistic, and you're like, I think I said supercalifragilistic, and everyone's like, you've been drinking? You're like, no. Right?
Yeah.
Awesome. Thanks for the share. Okay, Beth, who are you? And tell us what lights you up, dear.
Oh, hi, I'm Beth Huber. I'm a social worker at Baptist Healthcare Center in Bismarck, North Dakota. And of course, we work with a variety of situations, but including strokes and injuries. And one of my neighborhoods is more of a rehab neighborhood. And that's what's exciting, is when we can help someone rehab and get back to more independent living.
Love it. What lights you up, Beth?
I think that the rehab part of.
That's awesome. Fantastic. Love it, love it, love it. And so give me an example, or give all of us, excuse me, I'll speak with all of us, an example of a success that just keeps coming back and giving you that happy.
That's a good question. I don't know if I can think of just one particular. I guess I would probably think of it more as just in general, the success stories, not just one. Everybody's so different, different situations and different level of need.
Sure.
Yeah.
Awesome. Thank you so much. And Pamela, I can't get the last name.
Yeah, Schessler.
Pamela, please turn on your camera. Show your beautiful face. She being shy?
I don't know. Yeah, maybe she's not there.
Maybe she's not there. That's okay. How about Raisa Velez? Did I say that right, Raisa?
Yes.
Did I say it right? Nice.
Raisa, yeah.
Raisa.
Well,
what do you do? Tell us what lights you up.
So I am a case manager at Brain Injury Services. I work with our veteran population in basically the Northern Virginia area. I am an occupational therapist, but right now I'm working just like case management. So basically what I do is with the clients that are referred to me, you know, we talk about what their goals are, what are the things that they're wanting to achieve. So most of my clients are higher level.
Higher level functioning, is that what you mean by that?
Higher level functioning, yes, exactly.
Okay.
So,
and I don't know if that's the wrong or right term, but their level of function is such that independence is in their favor.
Yes, yeah, the majority. I'm not all of them, but the majority of my clients, because it's community based. That's what I mean. Like they're kind of higher level in the TBI and brain injury. So in terms of what lights me up, you know, I just doing some good for the community, doing some good for the world. And in terms of what are some of the common things, so again, I see a big range, right, of functioning levels. But one of the most, because most of my clients are in the community and they are independent, the most common thing I see in them is going to be overstimulation and being basically overwhelmed by all the sensory input. And so a lot more of like on the executive functioning side, like deficits that kind of get in the way of their day-to-day lives. So
What tool have you used that has been consistently helpful in helping them continue to be successful in their community? What's one thing that you can equip them with to be able to have that success on a daily basis where they can be in commitment to it?
in commitment to it, you said?
So like, what can they commit to as a tool that you give them that is something that they know and they have seen measurable improvement in their ability to do what they need to do? Is there something that you can share?
We've our services are very much client centered, so that is in a way that's something that kind of simplifies the job, is that I only work on things that the client wants to work on. It's very client driven. What do you want? And if it's so then that makes it easier to then, okay, well, I'm going to help you with what you want, right? Achieve that goal.
So I don't want to get overwhelmed when I go into my community. How can you give me some guidance?
So what I would do as a case manager, the first thing that I try to do is try to get them the tools to really understand what's going on. So we often refer to get a neuropsychological evaluation. That way, that gives them a little baseline of what their strengths are and what their weaknesses are, and then from there, we then kind of refer out. So some individuals just a big thing as well is actually going to be the identity loss and the grieving of like who I used to be and versus my functioning now. So I often refer out to mental health services, and then if you're able to find someone that understands what brain injury is and the difference between a mental health situation and a brain injury situation, that's great. Thankfully, we have one in our organization, so that's helpful. So that's one of the first things. And then, as an OT, I'm a believer in neuro rehabilitative therapies. So I try to get them out to speech therapy or OT. If I refer out to OT, it's often going to be for skill building. So let's say someone's having an issue with reading, and this is what's getting in the way of them being able to get back to work or get back to school or something, then, just refer to speech therapy, refer to occupational therapy, so that they can then just, through repetition and working on those specific cognitive tasks can then improve on those in those areas.
Beautiful. Love it. Yeah, it's a tough one. There's nothing easy about it. And when you try and train a brain that fatigues very quickly, it's really hard to chunk away progress as fast as you would love to, because they do hit the wall. And then when they hit the wall, they get so overwhelmed. So totally. Kudos to you. Wonderful. Is Pamela, that's all we get for her last name up here. Is Pamela?
Pamela, you back yet at all?
Let's go to Cheryl Roy. Woo.
Okay, so Cheryl doesn't have access to a mic or a camera, so she typed in the chat for us, but she said, I am a manager in a residential long-term TBI rehab facility in New Hampshire. Love to work with those that have behaviors. I like to spend time to understand how best to help them communicate. Give them time to calm self. Often if you talk with them, they can explain what works best for them and what does not. Often people overtalk and try to control a situation. I like to help people understand that doesn't work well.
So Cheryl, I'm just going to reread yours. Can you type in the chat what you would define behaviors as, and is it in relationship to an injury of the brain, or are we communicating about someone is observing that there's an inappropriate behavior in comparison to what society would allow or be tolerant of? So is it in relationship to a trauma? Hopefully she can type that, but we'll wait for her to maybe give us some feedback. And other questions, can we have people just either wave, give me a thumbs up if you want to ask some questions so we can continue this grand conversation about how do we help these people that have suffered brain injury. How much time do I have, Carly?
You have about a half hour still.
Okay, awesome.
Till 3 o'clock our time.
So are there any questions right now from anyone that wants to shout out? You can unmute yourself. There's, no, that's Sarah. Anyone? No one, no one, no one? Okay, so I will then talk a little bit about, maybe I can just give some feedback on how I assess a client. Let's just take someone who has had a post-encephalitic infection and has had residuals from that, which number one looks like a change in facial expression. They become more flat in their affect. So you always want to look for that facial expression. You're not looking for sadness. You're not looking for anger. You're looking to see whether there is a flat affect. And that is really going to be, for you, a guiding principle of how much more information are you going to retrieve. And a flat affect doesn't mean they're depressed. It can mean that, but it also can mean many other things. You also need to know that the hallmark assessment for a brain injury or anything related to brain is their gait. You have got to watch how your clients walk if they're ambulatory. Because if you don't look at how they walk, you're not going to understand their coordination. You're not going to understand the stride of their gait, how big of a step they take or how short of a step they take. You're not going to be able to understand if they feel off balance or are off balance. There's a difference. They may say, oh, I thought it was going to fall. And you clearly were able to look at their gait, assess them, and see that they were in no danger. Their perception was that they were at times. You will see someone who may have a sense of motion or lightheadedness or dizziness or a sense of what they may call vertigo, where they truly are cantilevering and they have a tendency, which you'll see, to have a specific pattern that's always the same. For others, depending on if they have what we call oscillopsy, where the eyes are moving, then they're going to be teetering. You're going to also be able to see and assess their posture. You know, if they're festinating, we've seen that in people that have been diagnosed with Parkinson's disease, where in order for them to walk, they literally have to start almost falling to get momentum to be able to get from point A to point B. So if you are a clinician or a therapist or even a case manager, it's your duty to understand that you need to know the client, not just by a paper chart. And that might be a good thing for you, Raisa, to get really involved with your team, is to be in on an assessment of that client, whether it's on a Zoom or whether it's just a short, quick interview, to let them know that you are managing the case and making sure on the back end that you're going to facilitate their journey in the best way possible. And you're going to use your clinicians, you're going to use your therapists in such a way that you are supporting them and seeing what obstacles they have, because there tends to be a very discombobulated support system when we are communicating as therapist clinicians. Nobody wants to talk to anybody about what's going on. Nobody wants to inform and say, my observation is this, and they are passed off to this person or that person without any working diagnosis that is going to have any specific one thing that anybody's trying to change. And so all of a sudden you have a client coming in saying one thing, but the order says another thing. And you're like, how do you even facilitate this? How do you even help this person get there? So I think it's super important as managers or people that are administrating that your involvement in every individual client. Now you're going to pick and choose how many you can take. You're going to have another person facilitate another group because you're never going to be able to see everyone. But your support on the back end, the wizard behind the screen, is no less important for your therapists or your outreach to the community. And you're going to enjoy what you do a lot more. And you're going to start associating that file number and that name with a face, and that progress is something that's going to light you up. So those are really important parameters to look at. Certainly you can look at speech, you can look at their ability to, do a motor movement. I mean, when you start doing complex things like tap your finger, do this, do that, those are complex. Gait is complex enough for you to get all the information you need from an actual client. That's all I use. I'm like, walk down the hallway, walk back. I watch them, I video them. And then right away, I know where I'm going in the brain as a result of being properly trained, being trained by people who are looking at what does change one from being a human that's functional to a person that's sitting with less function, seated, lying down, leaning, where they can't go from point A to point B. So some of the things that we look at when we look from a neurologic aspect is the thing of gait and the facial expression. Huge, 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 huge. What you can also see with the facial expression is, especially, someone who, like for you, Sarah, your client that you can't get communication, can you make them laugh? And the reason I would do that, and I would make it not goofy time, but laughter time, because laughter results in air exchange. Laughter is more exhalation, and then you regroup by inhaling. It's more exhalation, which is what you need first. You always want to get rid of the old before you take on the new. And so when you can affect a client through laughter, a little bit of a lighter mood by doing some things that are silly, funny, and get them laughing, then I know it. I love him. He's awesome. What's his name?
What?
What's his name?
Doug.
Doug.
Yeah. But he smiles a lot.
Well, smiling is not laughter.
Yeah.
So smiling is not laughter.
That's
Literal motoric laughter. So, I mean, he's obviously just got a great spirit for what he's gone through. So eliciting laughter for you all in working, whether you are a person suffering with brain injury, you've got to realize how huge it is for you to spend time in laughter. And as Sandy said, I spend time in nature. That is the most important place for you to be every single day if you have a brain injury. You've got to go outside. You have to. And if outside for you in North Dakota or in Minnesota or in Pennsylvania, because it's still cold there, or in Bismarck, means to go and look out a window that has nothing in your way, that's still outside to your brain. And so by being outside, the simple oscillation of nature, God's presence, the oscillation of sound of nature, of the wind, of sun, as Sandy said, I need sunshine. She's right. She needs nature. What happens in the brain is nature puts the brain back into a reset, because that's where it knows the sounds that aren't artificial. It doesn't have to make sense of noise. It knows sound versus noise. So people don't have sound sensitivity. They have noise sensitivity. They're very different. Because when sound is the sound of nature, it will never dysregulate them, ever. If you have a hawk out there hawking, it won't dysregulate them. It will make them lean in. But if you make an artificial sound on a keyboard, or you make an artificial sound from a computer, right, or something like that, a device where there's reverberation and vibration that's not natural to that setting, and then you have obviously the interference with everything else in that room, they feel trapped, and that's how they behave. So they don't have a behavior, they feel trapped, and they go into survival, which is not a behavior, it's survival. They don't behave. They don't have a behavior problem. They have an issue with knowing if or if not, will I survive this, because they are threatened by that to the point where their nervous system is shutting down or it's engaging to attack. It has one or another choice, either flight or fight. That's it. And the majority of our clients live in flight and fight over and over and over and over every minute of their life. And you wonder why they may feel a little bit post-traumatically stressed out. It's not them replaying what they saw. It's everything puts them into startle and survival. And then they're like, I remember being in this scenario of my body feeling like it needs to flee. They're not going back there and replaying that every day, unless we ask them to, right? So, and I think that that type of therapeutic input's going to change in the future too, where we start to help desensitize the flight and fight response to the point where that person can learn a new baseline of tolerance, of being able to be in an environment where there may be noise and creating enough plasticity to start filtering it away. But I want you to also consider in the communication with anyone with a brain injury, the first thing that we do as clinicians or rehabilitation or case managers, we put way too much on that client. We're like, do this exercise, do the exercise, da, 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 la, da, da. It's gotta be one thing, one. How many things do they go home with? 500, 400 therapists, 500 exercises, and they're fit to be tied. And then we say things like, repeat that every hour on the hour. And they're like, you're nuts. I mean, they always are in agreement. And then they go home and they go like, are they crazy? Because our brain injured people didn't lose their brain. They're perfectly brilliant. They just can't communicate it the same way they once did. So it creates for them a level of work that they didn't know they would have to work so hard to do that. So be very aware of that level of fatigue, and knowing that there is always dysregulated sleep patterns. Many are on medication, so you cannot even judge their sleep because you don't know. And if their energy levels are already compromised, your ability to help them rehabilitate their brain is going to be a lot less, especially if you put a lot more into it. So as you know, spring and summer comes for some of us, do your rehab outside. If they have more sensitivity to light, so what? You know, find a shaded area, find something that is comfortable, get their permission to be outside, make sure they're obviously protected from the elements, and, you know, give them some cool sunglasses and go out there and start doing some of that retrieval of how much can you do today? How do you feel today? How is your energy today? And so I think that that will be, if you haven't had that paradigm shift of thinking, maybe that will be helpful as you talk to your therapist if you're an administrator or you are the therapist. So Cheryl Roy, thank you for answering, says it's hard to explain. Like to help others understand the behavior of a person is how they are communicating, and perception of appropriateness is a big factor. Yeah, I agree that it is a hard one. You know, all human motor action, so a frown can be labeled as a behavior, a smile can be labeled as a behavior, an outburst is all motoric. So you got to realize that people who have had brain injury don't have the same ability to filter their motor responses, thus having a tremor, thus having a pass point. So they don't have the ability to make a smooth movement. So their facial expression may also be as a result of a breakdown in the actual sequence of what their expression was intended to be, but our acceptance of what we felt or saw was. They may have some frustration behind it by all means. Because if it takes you so much energy to get out no, we may call it a behavior, and they're like, I was just trying to say no. And so we've got to really put on our, we've got to have a very soft shell, because they have to be able to trust that we are not hard and rigid. We're going to ask them to work hard, but we're going to be totally the cushion that they can lean into to get that recoup and that recovery that they so need. They just are, they're the hardest workers ever. They want to work, they want to perform, they want to win. Our patience level, because we have paperwork and we have other clients and we have these crazy schedules that people make up for us that we can't quite do it all. So that's okay. We can't do it all, but we can do one thing with that client, one thing every time. And when we see progress, and we can start a new thing. So if you're doing rehab, maybe get away from trying to do everything and get to the one main thing. And if that client can communicate with you what their one thing is, don't add a second thing. Do the one thing, because it starts to make sense to all of you. And they are that less confused, less overwhelmed, and more excited to actually be successful, along with you cheering them on to be successful. You're not there to be their cheerleader, but you are their biggest cheerleader, right? For all of us. We love our clients, love them to death, eat them up, just appreciate them so much for the opportunity to work with them, for hard work, for all of it. We're all in the same, journey. We want to help them, and we want them someday to help someone else. I mean, that's just the world we live in. So that being said, I'm going to open up the microphone. Somebody throw out a question in this direction for me so that we can have more conversation until we finish up here in about 18 minutes. Anyone? Okay, then I'm going to say, Kyla, unmute. And I'll ask you a question.
Okay.
My question to you
She's
is,
talking to me.
what's that, hon?
Oh, Mrs. Fisher.
No, I got people in the background, sorry.
Oh, I'm sorry. No worries. So, Kat, if you're a Wounded Warriors, if there was one thing that you could do for your clients that you have been unable to do because you didn't have the tools, you didn't have the know-how, you didn't understand maybe a different concept. From today's lecture, is there anything that you took away that you could go and implement to get them moving in a direction that's faster than?
I really like the how do you feel? I'm pretty good at reading my warriors, but I haven't actually, unless I can, unless they're totally just discombobulated and totally different than normal, I don't normally ask that. So I think that might be something that might be really good for me to work on. And how clear do you feel in your head? I have one warrior that I think I could use that with, because he just doesn't like to communicate. He just doesn't want to.
Because you're also a trained military person. You're a trained Marine. So you're gonna train and coach your clients the way you were trained.
All right, you have a nice
right?
day. Be careful.
Yeah. And that's good, but
Thank you, sweetie. Bye.
they have to be the ones that drive that session, because it's not about you, it's about them.
Well, that's exactly right. And that's one of the goals for one of my warriors is, planning our sessions. And so when I first started working with him, I'm like, well, what do you want to do? I don't know. So then I would pick something, and come to find out it wasn't really like what he wanted. So finally I just said, you know what, it's up to you. You tell me what you want to do, because this isn't about me, it's about you.
And literally asking him, hey Joe, how you feeling today? Feeling pretty lousy. Are you feeling in the state of wanting to do some work today? Maybe we could do stuff a bit different today. Maybe it would would it be okay if we went outside today, Joe? Is there a place where you really enjoy going to, where you feel more relaxed? And that's
Mhm.
when you can start to say, Joe, why don't we just plan to meet here every week? And, you know, if that's a place where Joe relaxes, Joe's going to come with a different spirit and a different mindset. And, you know, you're going to create that relationship, Kyla, with your wounded warriors, that it is not a therapy session. It's actually a session of growth and stretchability.
Yep.
I just need to stretch you a little bit, buddy, because I need you to get stronger. And you know that you can't get stronger if we don't stretch you. You remember the days of us going to boot camp and training, right? They didn't
Yep.
like just kind of press you. They stretched you. They didn't push you. They stretched you.
Hmm.
It's way easier to get pushed. Stretched is harder because that's when growth occurs. So, you know, as a facilitator for these wounded warriors, use coaching, Kyla, in your way to actually communicate with them. Coaching is going to give you the way to communicate with them.
Yeah, yeah, and I've learned that, you know, especially with the one guy, you know, and because I can tell them all day what I think they should do, but if I can coach them through it and get them to see the outcome is what they want, then they'll just start doing more and more and more.
Yep, 100%. Great feedback. I wish you well. I have your contact
Thank you.
info, and I'll make sure we reach out to you.
Appreciate it. Thank you.
You are
This was
where?
great.
Where in Arizona are you?
Chandler?
Oh, okay. I know where that is. Nice. Let me write that down. Perfect. Thank you, Kyla.
Thank you.
Appreciate you being here. How about you, Beth? Can you unmute and give us some feedback on things that may have sparked or had shifted, maybe how you might want to do some things in your environment, your world out in Bismarck?
Yeah, I liked what you had to say about sound sensitivity versus noise sensitivity. I think as staff, we can get accustomed to things that our residents might be more sensitive to as noise. So,
So what's an example that when you look at your facilities, what could you take away today that would make their lives different or change? What's available, do you think?
yeah, we've already done some change where, for example, we use walkie-talkies or phones instead of overhead paging, which is more noise to people than helpful if you're not a staff member. But I think maybe just being more aware of the noises around us and how that's affecting the residents, because we can tune things out that they can't.
Yeah. And I would just maybe in some of your staff trainings or staff meetings say, you know what, we have a certain level of actual conversation. So if you're outside a client's room or you're in a transition from one area to another, that we keep it at a 4. That's the level that we talk at. We keep the facility quiet. And, you know, that's a game changer. Sometimes when you're doing rehab with your clients, reducing the overhead light, it quiets the nervous system down. So dimmer switches would be a good availability to have, not only for staff members because they get overwhelmed too, but that is noise as well. As soon as you shut some of that overhead, it's like, oh, you melt. You'll feel it as a human being that feels everything normally, and someone who feels it excessively, they'll be like, thank the good Lord you turned that down. You know, I didn't realize how much it made me crazy. So I think just the actual conversation level in your facilities should be toned down. There's no reason. And you know what will happen with your coworkers? You're going to have way better communication. When people talk quieter, people lean in and listen. And now you only have to repeat yourself just the one time. So it's quite a good trick to use. You know, you, Beth, right now, I haven't met you other than here, but you're a quiet individual. You speak calmly. I have a blowhorn in front of me. I need to work to speak quietly, but I can be trained to do it. So consider that as an element of getting rid of noise as well. Thanks, Beth.
Thanks.
Great feedback. Nora, how about you, my dear? Who said that she shouldn't be here? Of course she should be here.
Well, one thing you said in particular caught my interest because my speech therapist or cognitive therapist, for quite a while, I sort of complained to her that I wanted to work on processing. I can't get the terms right. It was basically getting stuff out that I could use it out of the back of my brain or wherever the hell it is. And it was processing something. And I wanted to work directly on that more because she's been more recently working on just getting more functional, though, like workarounds to work around what my problems are. And that's been helping. But anyhow, she told me that I need to get outside and I need to walk outside. I was like, I don't want to. And she said, well, that's one of the best ways you can work on that. It's like, oh, geez. So if I'm asking her to work on that and I refuse to do what she's asking me to do to work on it, I guess I don't have much to say about it. So what you said really hit me. It just kind of revalidated what she said, that I probably need to get out there and do some of that.
You know, and you don't have to necessarily, Nora, go out there and walk, but you just need to go out there and be. Just be part of the world. Just go out there and be. Be part of the universe. Be part of the day. Be part of the sunshine. Be part of the clouds. Even be part of the rain. If you are bundled up warm enough wherever you live, be part of the cold. Just be. It's an amazing place to be because as I look at where you live, it's very closed. It's got closure, right? And so your nervous system likes novel new things. When you're in wide open spaces, you're going to seek out information. In your home, you're mostly aware of everything in your home, as most of us are. We know where things are set. We know where things are. So there's not enough novel interest for the brain. So when you're out in nature, a sound that you hear, it's interesting. You literally will have a lean into it. Or something that runs by, a squirrel, if you're sitting in the park, you will watch it. You will want to know where it goes for whatever reason. You don't need to know, but you're going to watch that squirrel and you're going to be like, what's that little guy up to? And then pretty soon you see my dog attacking the squirrel. You're like, oh, I better go inside now. Because I just witnessed a lack of squirrel in the yard, right? So consider the novel things that nature bring to us, things that we didn't expect, things that are random. The randomness is what the nervous system learns from. It doesn't like the same thing over and over again. That's why we can only get to one place with rehab. It has to be novel. It can't be the same. It has to be different.
Feels so much safer though.
Yeah, safety is the feature, right? Yeah, for sure.
Yeah. And
So
probably,
it's up to you.
just to let you guys know, probably the thing that has helped me the very most with all.
Oops, you muted yourself. You muted yourself.
Sorry.
There you go.
Thing that's helped me the most with my cognitive therapist is, like, I've had people in the past tell me, break it down into small steps. Well, okay, we do that. And it was still completely overwhelming. And I couldn't do it, even the first step. And then with my cognitive therapist, we really broke it into small steps. I mean, they were this big instead of that big a small step. They were this big, and all of a sudden I could start doing stuff. And it made all the difference in the world to me. And that's what's gotten me probably as far as I've gone now to get more functional. That was the biggest thing she taught me and that I use. So I just wanted to say that.
That's brilliant. Awesome. Thank you for the share. Lori, I'm going to have you give us a shout out and then I'm going to close it up 2 minutes early. You could give us some feedback.
I thought it was all great information and thank you very much. I've
Thank
never You know, the killer, yeah, absolutely. I've never heard anything about the gravity or the gait to look at that. You know, the concept behind gravity and how that affect and how you can assess. So yeah, no, thank you. All awesome information that I know that I will be able to use. So thank you very much.
Thank you, Lori.
Do you have anything like online or resources, or you have so much knowledge? I don't want to have it stop here.
Yeah, you know what? We're right now rebuilding our website, but you can get onto our website and just do some learning there. And I'll write them in the chat here. I'll give you two of the things. The one thing, my practice website is what is claritybraincenters.com. And then my technology called Siraset.com, which I encourage each and every one of you to research, has been a game changer in the lives of many in the Fargo area, Moorhead area of North Dakota, Minnesota. Siraset is a technology, and it was actually born in Scottsdale, Arizona. And I'd like you to check that out, Kyla, because our headquarters are in Scottsdale. All of our studies for you, Kyla, have been done on the actual military. And our outcomes are tremendous. I'm looking at an article right now with our engineers. Functional brain network changes following use of allostatic closed loop acoustic stimulation neurotechnology for military related traumatic stress. Conclusions: use of our technology was associated with connection changes in the default mode and sensory motor networks in directions they may have explained the subject's clinical improvement. So the brain is all electrical. The world is using chemical. It's not going to be the future. We are the future. We're using it. We're applying this brilliant technology. We've studied it 22 years in the military. The outcomes on PTSD and the reduction in suicide are statistically significant. And so it is the game changer. Nobody knows us in the world yet. We were just released to the public within the last 18 months. We will change the world of brain. We are changing the world of brain. The hardest part is to be able to transition from a chemical model to an electrical model, is undoing all the chemistry that has changed people's brains, that has probably created more changes than the injury changed. So we have that obstacle to overcome. We also have one huge competitor in the world that is now available to everyone, and that is CBD. That stuff shuts down our brains. And now it's kind of like chewing gum. So we have that obstacle. We also have the obstacle of alcohol, because that also shuts down the brain. And so if people can refrain from those things when they go through our Siraset sessions, it's a game changer. When they use and compete with the brain, nothing can help the brain. So it's amazing technology. I'd love for you to check it out. If you're in the Fargo Moorhead area, we're located in Fargo. I'm bringing the next Siraset to South Dakota, Sioux Falls. The next one's going to go to Minneapolis, and then the next one, and then the next one, and then the next one. My mission is to make sure that our soldiers are taken care of first and foremost, and then of course our citizens who are suffering terribly. 2020 was a tough year on many people. People who never had mental health or emotional dysregulation or brain-based problems now do. There are many, many people who lost their jobs, lost their businesses, and they are in a desperate need for a reset of their brain as well. And so Siraset is the answer for them. So check that stuff out. I'll send you some info as well, Kyla. I'm working right now with the VA in Fargo and trying to create a facilitation between Wounded Warriors and this technology that we have, so that we can create a network of availability and get our soldiers better. For after all, they gave me my freedom. So I'm grateful. And for you
so much.
Anybody else who's serving, I tell you what, I'm going to serve this way because I wasn't able to serve the other way. So I appreciate each and every one of you. Thank you, Carly, for asking me to be on this call. I hope that it was worthy of your time.
Of course,
You guys
always,
are great.
yes, we always love to hear from you. And she'll be at our conference this year as well.
I will.
Quick little power hour session, but I think it'll be
Yes.
good too. So
I'll bring some power if I can get a chance, for sure. And it's really easy to bring power, because when your passion is behind all of this, you just do it, right? You just want to You just want the world to know that there are other things that are coming. There's always ever changing, and we've got to be at the forefront. And so don't ever compare yourselves in your journey with your clients as less important in their journey than the neurologist or blah, blah, blah. You are changing their lives. An MRI doesn't change anything. An MRI is used to confirm what your clinical exam already knew was going on. It's unfortunately went the other way. We're like, well, we don't know. Why don't you get an MRI? Well, wait a minute. Now you opened up a can of worms. And now we don't know what we're chasing. The one thing became a whole bunch of things, right?
Right.
So, all right, Carly, I'll leave it to you. Thanks, everyone.
Hey, thank you.
Awesome.
Yeah.
Talk to you
Anybody
soon.
else need anything else from me before we sign off at all, or any questions? Or Cheryl says, thanks for the great info. Very interested in your new research. Definitely
Yes,
see medications interfere and then more get added. Nora,
Yeah, for sure. For sure.
Nora, I didn't catch where you were from, but and it doesn't really matter where you're from, but if you ever want to join any of our virtual support groups, you're more than welcome.
Fargo.
Awesome. All right, you guys have a great one. Talk to you soon.
Okay. Yeah.
Thank you.
So we meet Mondays at 6, which Central Time. Are you in North Dakota, Nora?
Me? Yeah, Fargo.
Oh, you are?
North
Good.
Dakota.
Okay.
Yeah.
So yeah, we meet at 6 o'clock on Mondays, or we meet at 2 o'clock on Mondays, the last Monday of the month. So you're welcome to join in on those if you'd like to.
What are they like?
They're like this. They're Zooms, but they're a little less formal, and they're all survivors. Not that you totally, you're welcome to come to these and you come anytime, but I just wanted you to make sure you were aware of those as well. Because they're Zoom like this. So, and then we have different survivors come in. Our evening group is a bunch of ladies. Well, sometimes we get some men, but it's mostly women, and they're probably about your age, and I think you could relate to a lot of them. So.
Is there like usually a topic or just?
Usually, it's pretty, so we have Megan Dooley, who's an occupational therapist in the Bismarck area. She facilitates that an evening one. And so she does a little bit more of like the psychotherapy aspect of things, like emotions and their triggers and different things like that. The 2 o'clock one's a little less therapy wise. It's a little more just informal, and we kind of pick a different topic every time. But we are having our next topic for March is a fellow survivor, and she's presenting on self-compassion is the topic.
Oh, okay. So how do I find these?
Yeah, I was going to show you on our website where you can find the link. Let's see here. Got a lot of screens open today. Let's see. So if I'm going to show you my screen, okay, so you can see where to find. So this is our home screen here, this ndbin.org.
Oh, yeah, I've been here before because I see you guys on Facebook. That's how I found out about this.
Okay, good. Yes, and if you're our friend on Facebook, Nikki usually posts on Facebook about support group too. So you can always click on the link from Facebook, or you can go in this way, either way. But if you go under events and training, if you go upcoming events, then our virtual support group is right here. Here's the Mondays at 6. So you click on this, and then the link is right there for you.
Oh, okay. That's easy. I can do that.
A couple clicks, I hope so. We try to make it user friendly. And then the other one, here's the monthly one, because that's not till March 29th now. But same thing, you just click here and then click here.
Okay.
Yeah, and really any of these events you're welcome to join in on. We have virtual book clubs, office hours.
Oh, I wonder if I can't remember, but it might have been you that was talking to me. I have the, see if I can get it right, the subcortical vascular insufficiency. And I was emailing to get information.
Was that Nikki that you talked to?
That was you, Nikki?
Yep, we emailed. Yep.
Yeah, that's me.
Okay. Nice to meet you. I never heard your name, so I I wasn't sure, but
So
yes,
did
I
any of that
remember.
information help?
Oh, did you send?
Did we? Yeah, we sent you some information. Did that help at all, or?
Oh,